for the nature of disease, hepatic cirrhosis is a long-term and progressive condition of the liver where the normal liver tissue becomes permanently scarred, causing the liver to gradually lose its ability to function properly. So, in the case of the patient, she was diagnosed with liver cirrhosis that developed due to ulcers in her liver. So, because of additional health complications, she needed to take several medications. So, this medication placed extra strain on her already weakened liver and eventually led to episodes of bloody stools. For the symptoms, hepatic cirrhosis is a chronic progressive liver condition characterized by irreversible scarring of the liver tissue, so leading to impaired liver function and metabolic disturbances. So, for the symptoms include fatigue, weakness, and loss of appetite. So, other symptoms according to the Mayo Clinic. So, the other symptoms includes easy bruising, itchy skin, jaundice, and other symptoms also includes the nausea, weight loss, edema of the legs, dark colored urine, and as well as pale colored stools. So, for the causes, the condition develops when the liver is repeatedly injured, inflamed, or unable to perform its normal function. So, over an extended period of time. So, prolonged alcohol use and chronic viral infection gradually damage the liver cells, leading to fibrosis or scarring. So, without proper treatment, this ongoing damage can eventually progress to liver cirrhosis, according to Mayo Clinic. So, for the risk factors, so individuals with long-term alcohol consumption, individuals with chronic viral infections, as well as individuals with non-alcoholic fatty liver disease that are commonly linked to obesity, diabetes, and high cholesterol. Individuals with autoimmune liver disease are at risk. So, moving on to the complications. So, as the liver progresses, the liver gradually loses its ability to function and blood flow through the organs becomes restricted, so leading to serious complications. So, this includes portal hypertension, which can cause ascites and progress to bacterial peritonitis, toxin buildup, which may result in hepatic encephalopathy, affecting the brain function. Another is kidney dysfunction may also occur along with reduced production of blood clotting factors, increasing the risk of bleeding. So, in addition, patients may experience malnutrition and a weakened immune system, making them more vulnerable to infections. So, moving on to the epidemiology, so cirrhosis affects millions of people globally and often goes unnoticed until the condition becomes severe in many regions of Asia and Africa. So, chronic hepatitis B and C infections are leading causes of liver cirrhosis. So, while in Western countries, the disease is commonly linked to long-term alcohol use and poor dietary habits. So now, let's move on to the pathophysiology of the said disease. So in liver cirrhosis, continuous liver injury leads to scarring and distortion of the normal liver structure, which restricts the blood flow through the organ. So this increased resistance raises pressure in the portal circulation, resulting in portal hypertension. So to compensate, blood is diverted through alternative pathways, while widespread vasodilation reduces effective blood volume. So these changes activate the fluid-retaining hormonal systems, leading to ascites, kidney dysfunction, and other complications associated with advanced liver disease.
So now let's proceed to chapter 2. So to begin, let's look at its purpose. Fundamentally, food is essential for energy, healing, and recovery from illness. Clinically, liquid diets are used as therapeutic diets for specific purposes. They are primarily used for patients who are in the perioperative phase, meaning before and after a surgical procedure, those needing support for gastrointestinal problems, and individuals with oral dysphagia, that is, difficulty swallowing. A critical point to remember, liquid diets are generally not prescribed for more than 3 to 5 days without any supplemental nutrients due to the risk of deficiency. So to connect with the case of Miss AS, she was prescribed a liquid diet as a transitional diet to allow her gastrointestinal organs to rest and stop defecating bloody stools. Once that is controlled, she will progress to a soft diet, then to a normal diet. Moving on to the objectives for this presentation. By the end of this case study and discussion, we as future nurses should be able to acquire adequate knowledge of what a liquid diet is, define the liquid diet and differentiate its two types, citing different examples for each, recognize the proper indications and contraindications for using a liquid diet, discuss the potential complications that can arise, and finally, we will be able to formulate a meal plan and compute dietary calculations accurately for patients on this diet. Now, let's focus on the 4 key aims of using this particular diet. So this is to minimize mechanical and chemical irritation of the gastrointestinal tract by providing non-residue or digestible nutrients, to provide sufficient fluid and electrolytes to prevent dehydration, to provide nutrition in a form that is easily swallowed by patients with chewing difficulties, and critically, to cleanse the GI tract, which is necessary for certain diagnostic tests or surgical procedures like bowel preparation. So next is, we will discuss the definition of the diet. So liquid diets are therapeutic diets often prescribed by clinicians to prepare patients for procedures, treat GI conditions like gastritis or inflammatory bowel disease, and support post-operative recovery. So there are 2 main types that differ based on the patient's clinical need: clear liquid diet and full liquid diet. So clear liquid diet, what is clear liquid diet? This diet includes only clear liquid diets such as broth, excluding any solid foods or liquids that are non-opaque. So any liquid that is transparent. So now, what is full liquid diet? This diet contains fluids and foods that turn to liquid when at room temperature. Example of what is allowed on full liquid diet includes strained creamy soups, milkshakes, pudding, and popsicles. So knowing the definitions, let's look at when each diet is specifically indicated. So for clear liquid diet indications, this is commonly indicated for clinical needs such as procedure preparation, for example, before a colonoscopy, support for recovery, symptom management, and specific GI problems. As for full liquid diet indications, this is often utilized in cases of oropharyngeal dysphagia or difficulty swallowing. It is also used as part of post-operative recovery or when we are gradually advancing a patient's oral intake from a clear liquid diet. So now let's proceed to the important considerations and reminders. So when managing a patient on a liquid diet, here are some crucial considerations and reminders. A liquid diet is generally considered safe only for short-term use and must be under medical supervision. All food groups must be liquidized to ensure the right consistency for the diet. And hard consistencies, bread and pastry, eggs, or any consistencies that cannot be liquidized should be avoided. Finally, we must ensure the client is strictly following the prescribed diet and monitor their food intake and educate them of what is and what is not allowed. So now for the last part of the chapter, which is complications. We must be aware of this complications. So first is patients may experience hunger and nausea due to the inadequate amount of nutrients in the diet. The long-term dietary modifications can lead to poor nutritional status, and extended use is correlated with measurable conditions like dehydration and renal stress, particularly with long-term use of full liquids. A clear liquid diet specifically can rapidly lead to negative nitrogen balance and catabolism. And when used for too long, this diet can significantly increase the risk of metabolite and electrolyte imbalance. And metabolite and electrolyte imbalance lead to diarrhea, causing dehydration. The persistent loss of water and key minerals may lead to conditions like hypokalemia and dysnatremia. And one of the most severe complications is aspiration, especially when thin liquids are given to patients with oral dysphagia. This is why a full liquid diet is often preferred in these cases.
Good day to the panelists. I will be presenting my assigned portion of the case study, which includes the patient's anthropometric data, medical history, and socioeconomic background. Our patient is Asiya A. Sajail, an 89-year-old female who is widowed. She stands at a height of 5 feet and has a body weight of 53 kilograms. Patient Asiya Sajail presents with multiple chronic health conditions, most notably hepatic cirrhosis. She was admitted to the hospital due to bloody stools, which raises concern for gastrointestinal bleeding, possibly related to her underlying liver condition. In addition to this, the patient has coronary artery disease and atrial fibrillation with controlled ventricular response, both of which require continuous medical management to prevent further cardiovascular complications. She also has type 2 diabetes mellitus, necessitating strict monitoring and control of blood glucose levels. The patient has a history of cerebrovascular disease with infarcts, secondary to a previous episode of severe hyperglycemia with blood sugar levels reportedly reaching 500 milligrams per deciliter. This has contributed to her mobility limitations and cognitive decline. Furthermore, patient Asiya Sajail has glaucoma, which has already progressed to complete vision loss. At this stage, eye care is only focused on comfort and prevention of further complications. She is also experiencing symptoms of early Alzheimer's disease, which affect her memory and cognitive function, adding complexity to her overall care. In addition to these current conditions, the patient has a history of breast cancer, which required surgical intervention. She also experienced gallbladder failure, resulting in cholecystectomy. The patient previously had myoma, which likewise resulted surgical management. Due to the chronic and recurring nature of her illnesses, she has had multiple hospitalizations, although she is unable to recall the exact number. Notably, the patient reports no known drug or food allergies. At present, patient Asiya Sajail is managing severe chronic and progressive conditions. Her physical limitations are compounded by cognitive impairment associated with early Alzheimer's disease. This combination of physical and mental health concerns necessitates comprehensive, individualized, and long-term care. The patient's family history is significant for diabetes mellitus and glaucoma, both of which are also present in the patient, suggesting a hereditary predisposition to these conditions. Patient Asiya Sajail resides in a middle-class Filipino household, which provides a relatively stable environment. Her income consists of an 11,000 peso pension and an additional 5,000 peso monthly allowance from her children, placing her in a modest income bracket. Although financial limitations may restrict access to premium food items, the family is still able to provide nutritious meals through careful planning and prioritization of affordable, nutrient-dense foods. The patient is of Tausug ancestry, and her dietary habits are influenced by her cultural background. Her meals typically include traditional Tausug cuisine, which emphasizes flavorful and fresh ingredients. Occasionally, she consumes small portions of food served during Filipino gatherings, such as pancit and other viands. The patient lives with and is supported by her children. Her family includes Adian El Sajail, her son, age 57, Nasiha El Sajail, her daughter, age 55, Marhama El Sajail, her daughter, age 53, and Abdurrahman Jr. El Sajail, her son, age 48. Patient Asiya Sajail is a retired teacher and holds a Bachelor of Elementary Education degree. Her educational background suggests that she has the capacity to understand health and nutritional advice, which can facilitate compliance with dietary and medical recommendations. The patient practices Islam, which significantly influences her dietary choices. She strictly follows a halal diet, avoiding haram foods such as pork. This religious consideration is important when planning meals to ensure both nutritional adequacy and cultural appropriateness. Patient Asiya Sajail lives in a cemented, middle-class Filipino home, which provides a safe and clean environment for food preparation and storage. The patient stays in a fully air-conditioned room equipped with a hospital bed, ensuring comfort and safety given her bedridden condition. Most of the patient's income is allocated to medications, medical expenses, and personal needs, while her children shoulder the cost of food. This highlights the importance of cost-effective yet nutrient-dense dietary planning. For the patient's recreational and physical activities, the patient enjoys relaxing in the garden, which contributes to her emotional well-being. However, due to the difficulties with walking and standing, she requires assistance and occasionally uses a wheelchair. Her limited physical activity may impact her mobility and metabolism. Patient Asiya Sajail presents with complex medical, social, and cultural factors that must be considered in her overall management. These factors highlight the need for holistic, patient-centered care tailored to her physical limitations, cognitive status, socioeconomic situation, and cultural beliefs.
Dietary history, food likes and dislikes. The patient typically enjoys eating vegetables such as cabbage, carrots, and tomatoes, usually prepared sautéed or in soups, and she is especially fond of chop suey. She also enjoys traditional Tausug dishes like pianggang, kulma, and yula itum. During gatherings, she occasionally eats these foods along with pancit and other viands in small portions. Typical food intake. The patient meals are consistent daily and consist of 5 meals: breakfast, lunch, supper, and 2 snacks. Her meals include stir-fried vegetables, rice, and fish as source of protein. Frequency of meals and time eaten. The patient consumes 5 meals daily, including breakfast, lunch, supper, and 2 snacks, mid-morning and mid-afternoon. Her meals are eaten at regular intervals, with breakfast at 8 a.m., snacks at 10 a.m. and 4 p.m., lunch at 12 p.m., and supper at 7 p.m. Food facilities. The patient meals are prepared at home using common cooking methods such as stir-frying, boiling, grilling, simmering, and frying. For meals eaten outside, she sometimes chooses chop suey from Mang Paeng's restaurant, which is her preferred option. Food budget per person. The patient has a food budget of 500 pesos, primarily covers simple home-cooked meals, with occasional purchases such as chop suey from Mang Paeng's restaurant, which costs approximately 260 pesos per serving. Other sources of nutrients in addition to usual food and drink intake. The patient's nutritional intake is supplemented by various medications and health products that contribute to their overall well-being. Maintenance medications such as the following: Pectavas. The patient uses it to reduce inflammation and to alleviate gastrointestinal discomfort. The Ketobes. The patient uses it to improve protein metabolism and manage uremic toxins related to chronic kidney disease. The Jardians. The patient takes it to lower her blood sugar levels due to type B diabetes and to protect her kidneys. Apixaban. The patient takes it as an anticoagulant to prevent blood clots associated with atrial fibrillation. Next is the Carvid. The patient takes it to lower her blood pressure and also to reduce the workload on her heart. Linagliptin. The patient takes it to control her blood sugar levels by enhancing insulin production for her type 2 diabetes.
Immune Pro. The patient uses it to support her immune function and promote overall wellness. Evetra, the patient takes it as an anticonvulsant to control seizures, particularly following her stroke. And lastly is Sequantia. The patient takes it to help stabilize her mood and manage agitation or behavioral symptoms following her stroke. Past dietary restrictions and medical reasons. So the patient requires specific dietary measures to support gastrointestinal, hepatic, and cardiovascular health. With a history of peptic ulcer disease and gastric sensitivity, the patient must avoid spicy, acidic, and heavily seasoned foods as this can irritate the stomach lining and trigger ulcer symptoms. Nutritional knowledge and were obtained. The patient obtains general information on food content and dietary guidance from their family doctor, a pulmonologist. Dietary needs while in the hospital, food likes and dislikes. The patient has no identified food likes or dislikes as she was unable to consume solid foods. Her intake is limited to a liquid diet, which restricts her ability to express preferences for specific food items. Present dietary prescription and rationale. The patient was placed on a liquid diet for 2 weeks to manage episodes of hematochezia or the pooping of blood, which were caused by underlying liver dysfunction. Appetite and ability to chew. The patient had a reduced oral intake and required a liquid diet for several days. Her chewing ability was not compromised, but she experienced swallowing difficulty and recurrent vomiting, cramps, or abdominal distension. Any physical handicap? The patient is able to feed herself independently using her own hands. She demonstrates sufficient motor coordination and hand-to-mouth ability to manage her meals without assistance. Food tolerance. The patient was able to adapt well to the liquid diet, maintaining adherence and composure throughout the period, which lasted up to 2 weeks. Her strong mindset and determination to improve her health enabled her to follow the dietary restrictions despite the challenges of consuming only liquids. Need for dietary instruction. Proper dietary nutrition was provided to support the patient's recovery. The patient and her family were instructed on how to gradually resume oral feeding, following a low sodium and low glycemic diet, and to incorporate foods rich in nutrients to support liver health and overall recovery.
For the nutrition care process, the nutrition problem number 1 is the nutritional. For the nutrition assessment, you have poor oral intake during hospitalization, only consumes 2 spoonfuls per meal, frequently sleeps for long periods, and has poor appetite. Reports of painful swallowing and recurrent vomiting of saliva. The diagnosis for this is inadequate oral intake related to poor appetite, painful swallowing, and vomiting as evidenced by intake limited to 2 spoonfuls per meal, frequent skip meals, and dehydration during admission. For the intervention, we have provide small frequent feedings with smooth and strained liquids. Nutrient-dense broths and pureed vegetables will be used to increase energy and protein intake. Caregivers will be instructed on proper feeding practices and maintaining a low-sodium liquid diet appropriate for liver disease. For the monitoring and evaluation, the client will be monitored for improvements in intake, reduced vomiting, and better tolerance to feedings. Stool appearances will be observed for occurrence of bleeding. Hydration and caregiver adherence to feeding instructions will also be assessed to determine readiness for soft diet progression. For the nutrition problem number 2, which is for the anthropometric, we have the assessment. The client weighs 53 kilograms but is bedridden with weakness and low energy. Her severely limited intake during the liquid diet and frequent missed meals place her at risk for further nutritional decline. The diagnosis for this is inadequate energy intake related to extremely low oral intake as evidenced by minimal food consumption and physical weakness. The intervention is to increase energy intake by providing fortified liquid meals and offering feedings more frequently when the client is awake. Caregivers will record intake to help monitor improvements. For monitoring and evaluation, we are to monitor intake logs and observe for signs of improved strength and energy, and also to evaluate whether feeding frequency and volume increases over time. The last nutrition problem is the nutritional. The assessment is the client has liver cirrhosis with recent gastrointestinal bleeding, causing abdominal discomfort and vomiting. She was placed on a liquid diet to prevent further irritation of the gastrointestinal tract. The diagnosis for this is altered gastrointestinal function related to liver cirrhosis and GI bleeding as evidenced by episodes of pooping blood and a need for a liquid diet. The intervention is to continue the prescribed liquid diet using low-fat and low-sodium options to reduce gastrointestinal irritation. Feed slowly to lessen vomiting and coordinate with the medical team for safe diet advancement once bleeding stops. For the monitoring and evaluation, we are to monitor for any recurrence of blood in stool, abdominal discomfort, and vomiting. Evaluate hydration and overall tolerance to determine when transition to a soft diet is appropriate.
So now we are to proceed to the computation of our DBW, or desirable body weight. We are going to utilize the Tannhauser's method. So step 1, we have to measure the height in centimeters. Step 2, we have to deduct a constant factor of 100. And the garnered difference would be the DBW in kilograms. Then step number 3, for Filipino stature, we are going to deduct another 10% to our previously garnered difference. After this, we have our DBW in kilograms, and we have the optional step to convert it to pounds via the factor 2.2 pounds per kilogram. So we have previously mentioned that the height of our client is 5 feet. Given this, we have to convert it to centimeters. But first, we have to convert it to inches. We know that 1 foot is 12 inches. So 5 feet times 12 inches gives us 60 inches. So 60 inches is then multiplied to a factor of 2.54 centimeters per inch, which gives us a height of 152.4 centimeters. So for step number 2, we have to deduct a constant factor of 100 in order to get our DBW in kg. So 152.4 centimeters minus 100 kilograms per centimeter via the process of cancellation gives us 52.4 now kilograms. So next, for DBW obtained applied to Filipino stature, we take off 10% of that 52.4 kilograms. So what is 10% of 52.4? It is 5.24. So 52.4 minus 10%, or 52.4 minus 5.24 gives us 47.16 kilograms for our DBW in kilograms. So we have the optional step to convert this to pounds. So to convert kilograms to pounds, we multiply the kilograms to a factor of 2.2 pounds per kilogram. So 47.16 kilograms times 2.2 pounds per kilogram gives us the DBW in pounds of 103.752 pounds. So next, we are going to move on to the body mass index, or the BMI. So for this, we are going to divide the weight in kilograms to the height in meters squared. So given that we have a weight of 53 kilograms and a height of 1.524 meters, we are to divide 53 divided by the quantity of 1.524 multiplied by itself 1.524. So we have a BMI of approximately 22.81 kilograms per meter squared. So given that this is within the range of 18.5 and 24.9, this is considered normal. So now we move on to our TER, or our total energy expenditure. So we are going to be utilizing the Harris-Benedict equation for females, hence the basal energy expenditure. So how do we get our basal energy expenditure, or BEE? We get this by adding 655 plus 9.6 times weight in kilograms, plus the quantity of 1.8 times height in centimeters, minus the quantity of 4.7 times age in years. So we know that the weight of our client is 53 kilograms. She has a height of 152.4 centimeters and an age of 89. So our BEE is equals to 655 plus the quantity of 9.6 times 53 plus the quantity of 1.8 times 152.4 minus the quantity of 4.7 times 89. So we get a BEE, or a basal energy expenditure, of 1019.82 kcal. So in order to get our TER utilizing our computed BEE, we are to multiply our BEE to the activity factor and the stress factor of the client. So TER is equals to 1019.82, which is the BEE, times the activity factor of 1.2, given that the client is in bed rest, and a stress factor of 1.3 with the client having moderate stress. So our TER after this is 1590.91, or approximately 1591 kcal per day. So next up is our percentage distribution, in which our total energy expenditure is to be divided into three nutrients: carbohydrates, proteins, and fats. So the TER is to be split up into 55% carbohydrates, 15% proteins, and 30% fats. So now we move on to the specific computations for the percentage distribution, starting off with carbohydrates. So for carbohydrates, we multiply the TER to 0.55 or 55%, and we get 875.05 kcal. So this is to be converted into grams, in which we're going to be dividing this by the equivalent of the carbohydrates. So 875.05 kcal divided by 4 kcal per gram gives us 219 grams. So for protein, it is the same. The TER multiplied by 0.15 or 15% this time equates to 238.65 kcal. So the equivalent of protein is the same as to carbohydrates, which is 4 kcal per gram. So 238.65 kcal divided by 4 kcal per gram is equals to 60 grams. So lastly, for fats. For fats, the fat equivalent is higher than the protein and carbohydrate equivalent. So we have the TER 1591 multiplied by 30% equals to 477.3 kcal. So as mentioned earlier, it is higher, so 477.3 kcal would be divided into 9 kcal per gram instead of 4, which gives us 53 grams. So to recap, for carbohydrates, we have 219 grams, for protein, 60 grams, and for fats, 53 grams.
So now we proceed to the sample meal menu, beginning with the food exchange list. We have to take note that everything under the food exchange list is based on the percentage distribution from the total energy requirement of our patient. So first, we have 4 exchanges of either strained or pureed vegetables, which contains 12 grams of carbohydrates and 4 grams of protein, which provides the patient with 64 calories of energy. Next is 4 exchanges of fruits, which are either strained juice or pureed, which contains 40 grams of carbohydrates and provides 160 calories of energy. Next is 2 exchanges of low-fat milk, containing 24 grams of carbohydrates, 16 grams of protein, and 10 grams of fat, providing for 250 calories of energy. Next is 3 exchanges of rice A. This contains 69 grams of carbohydrates and provides 276 calories of energy. Next, we also have 3 exchanges of rice B, which is strained cereal, which provides or contains 69 grams of carbohydrates, 6 grams of protein, and provides 300 calories of energy. Next is 4 exchanges of low-fat meat. This contains 32 grams of protein and 4 grams of fat, accounting for 164 calories of energy. Next is emulsified fat, so 6 exchanges of emulsified fat, which contains 30 grams of fat, accounting for 270 calories of energy. Next is 2 exchanges of dissolved sugar, providing or containing 10 grams of carbohydrates, providing 40 calories of energy. So we are able to arrive at a designated calorie count by keeping in mind that for every gram of carbohydrates, there are 4 calories of energy. For every gram of protein, there are 4 calories of energy, and for every gram of fat, there are 9 calories of energy. So when we solve and compute for the food exchange list, we have a total of 224 grams of carbohydrates, 58 grams of protein, and 48 grams of fat. This gives us 1,524 calories of energy. So you might be wondering, this is not exactly the same as the percentage distribution or the total energy requirement. So accordingly, we have to take note that the values are adjusted for a liquid or soft diet using a strained, pureed, or blended food forms. So the slight variation from the computed requirements is acceptable within the food exchange system. So we now move on to the distribution of exchanges. So for the first meal of the day, which is breakfast, we have one exchange of vegetable, one exchange of fruits, 1.5 exchange of both rice A and B, one exchange of low-fat meat, and one exchange of fat. Next is for the AM snack. We have one exchange of low-fat milk, one exchange of fat, and one exchange of sugar. Next is lunch, one exchange of vegetable, one exchange of fruits, two exchanges of rice A and B, two exchanges of low-fat meat, and one exchange of fat. Next is for the PM snack. We just have one exchange of fat. After that is the supper, one exchange of vegetable, one exchange of fruit, one exchange of low-fat milk, two exchanges of both rice A and B, one exchange of low-fat meat, and one exchange of fat. And lastly is for the midnight snack, one exchange of vegetable, one exchange of fruit, 0.5 exchange of both rice A and B, one exchange fat, and one exchange of sugar. So this accounts for the total exchanges which can be found in the food exchange list in the previous part. So based on the distribution of exchanges, we have come up with a sample one-day menu. This is based on the fact that our patient has specific foods that can and cannot be taken. So first is for the breakfast. We have decided for the sample menu to give strained tomato soup, which is 3 tablespoons in household measure, 3/4 cup of papaya puree, 1.5 cup of plain lugaw, and 1 slice of blended boiled bangus. For her AM snack, we'll be giving low-fat milk, 1 cup, 2 teaspoons of white sugar dissolved, and 1 teaspoon of canola oil. For lunch, we'll be giving her a half cup of carrot puree, half cup of banana puree, 1.5 cup of rice cereal, which is strained, 2 slices of blended chicken breast, 1 teaspoon of olive oil. Next is the supper. For supper, we'll be giving her 1/2 cup of sayote puree, 3/4 cup of pear juice, which is strained, 2 cups of lugaw, which is also strained, and a half cup of blended tofu. Lastly, for the midnight snack, we're giving 3/4 cup of apple juice, which is strained, 1/2 cup of rice cereal, 2 teaspoons of white sugar dissolved, and 1 teaspoon of MCT oil. So as you can notice, the meals given to the patient is decided based on what is applicable and not applicable. So most of the foods are done and prepared in a technique where it can easily be digested by the gastrointestinal tract, avoiding irritation. So we now proceed to the procedure of meal preparation. So we are going to focus on the lunch menu. So for the lunch menu, we have the carrot puree, banana puree, homemade rice cereal from white rice in strained, blended boiled chicken breast, which is low-fat meat, and the olive oil, which is added after cooking. Next is the ingredients, which is equivalent to 1 serving. So we'll need half cup of peeled and sliced carrot and 1 cup of water for the carrot puree. We'll also need a half cup of sliced ripe banana lakatan for the banana puree. For the homemade rice meal, we need 2 tablespoons of raw white rice and 2 to 3 cups of water. For the blended boiled chicken breast, we need 60 grams or about 2 thin slices of chicken breast, which are skinless. We'll also need 1 cup of water. And lastly, for the fat, we'll need 1 teaspoon of olive oil, which will be added later on. For the equipments needed, we'll be needing a knife and chopping board, a saucepan, stove, blender, fine strainer or cheesecloth, measuring cups and spoons, and serving bowls. So now we proceed to the step-by-step procedure. So first, of course, we have to follow as a universal standard the general food safety preparation. First and foremost, we have to wash our hands thoroughly with soap and water. To use apron and gloves if needed. Clean all utensils and cooking equipment, and also to use potable water and fresh ingredients. Lastly, we have to make sure that we prepare our food in a clean environment. First is the preparation of carrot puree. First, we have to peel the carrot and slice it into small pieces. And then we're going to place these pieces in a saucepan and add 1 cup of water. We'll then proceed to boiling it for 10 to 15 minutes or until the carrot is soft enough until it can be sliced by a fork. Next is to transfer the cooked carrot and cooking liquid into the blender. And then we're going to blend it until it is completely smooth and strain it using a fine strainer to remove fibers. And then we'll set it aside. Then we'll proceed to preparing the banana puree. So this is the easiest among the others to prepare because we'll just be needing to peel the ripe banana and slice it into the small pieces, and then place these slices into a blender and then blending it until it's smooth, straining as well to get rid of the fibers and achieve a thin consistency. And if you might, you can also add water to easily reach this thin consistency. And then after that, we're going to be setting it aside. So next is preparing the homemade rice cereal. So this is similar to preparation of the lugaw. First is we have to wash the white rice thoroughly and then place the rice in a saucepan and add 2 to 3 cups of water. We have to cook the rice over low heat for 20 to 30 minutes until the rice is very soft and overcooked. We'll allow this to cool slightly thereafter and then transfer the rice and the excess water into a blender. We'll then proceed to blending it until it is completely smooth and then straining it using a fine strainer or cheesecloth to remove the remaining grains, making sure that it is very liquid in consistency. And then if necessary or if possible, we'll reheat it gently if needed and ensure that it is a thin, smooth consistency. And then after that, we'll now set it aside. Then after that, we can now prepare the blended boiled chicken breast. So we're going to place the skinless chicken breast in a saucepan and then add 1 cup of water. We're going to boil this for 15 to 20 minutes until it is fully cooked. And then we can now remove the chicken and let it cool slightly. And then we're going to cut these chicken into small pieces and place it into the blender. And additionally, we'll also add a small amount of the cooking broth. And then we're going to blend it until it is smooth, strain to remove any solid particles, and then set aside. And then lastly is the additional fat. So to add this fat, all we need is to add 1 teaspoon of olive oil into the blended chicken, and then we have to make sure that we mix it thoroughly before serving. So to serve it, basically we have to serve all components warm and not hot. This is to ensure that the patient can eat it without difficulty and eat it with ease. We have to also ensure that all foods are smooth, thin, and free of solid particles because our patient is under a liquid diet, meaning that we must avoid big particles that are hard to swallow and to digest. Next is to discard the leftovers after 24 hours. So what is the rationale behind this specific lunch meal? So this meal was prepared by using different techniques of boiling, blending, and straining to produce a low residue, liquid or soft diet which is appropriate for a patient with hematochezia. Carrot was selected as a vegetable due to its mild flavor and low fiber content when it is strained, and it's also easy to digest. The lean chicken breast provides high biologic value protein with minimal fat, supporting the nutritional needs in hepatic cirrhosis while minimizing the gastrointestinal irritation.
So given all things considered, this case of an 89-year-old female with advanced liver cirrhosis, multiple comorbidities, and recent hematochezia highlights the critical role of nutritional management in preventing further complications and supporting overall patient stability. Due to impaired liver function, reduced metabolic capacity, and gastrointestinal distress, the patient is unable to tolerate regular oral intake and is therefore placed on liquid diet therapy to minimize gastrointestinal irritation, maintain hydration, and provide easily digestible nutrients. Liquid diet therapy served as an important intervention for reducing bowel workload, preventing further bleeding episodes, and supporting the patient's limited digestive capacity. This diet also aided in maintaining electrolyte balance and preventing malnutrition, which is an appropriate and important consideration given her frailty, age, long-lasting disease burden, and her bedridden status. Overall, the nutritional intervention was essential in stabilizing her condition, providing comfort, and preventing aggravation of gastrointestinal symptoms while carefully considering her compromised liver function and multiple chronic illnesses. Here are a few recommendations relating to this case. So, number 1 is to continue a modified liquid diet according to tolerance. We have to maintain the liquid diet and adjust consistency based on the patient's ability to tolerate intake without discomfort. Number 2 is to prioritize liver-friendly nutritional choices. We have to provide liquids that are low in fat and sodium to reduce liver workload while supporting nutrition. Next is frequent small feedings. For number 3, we have to offer small amounts of liquids at frequent intervals to improve digestion and tolerance. Next, we have to monitor for signs of intolerance and gastrointestinal bleeding. So here we have to look for symptoms such as nausea, vomiting, abdominal pain, and signs of bleeding such as black stools or blood and vomit. Next is electrolyte and glucose monitoring. We have to regularly check electrolyte and blood glucose levels to detect and manage imbalances early. So next, we have to consider some supplementation. So supplementation, aside from the liquid diet itself, we have to give prescribed vitamin or mineral supplements to address potential nutritional deficiencies. We have to collaborate with the multidisciplinary team. We have to work with physicians, dietitians, and other healthcare providers to ensure appropriate nutritional management. And lastly, we have to reassess nutritional status regularly, in which we have to continuously evaluate intake, weight, and laboratory results to guide necessary dietary adjustments. That wraps up our case presentation. We thank you for listening.